Hello, and welcome to the COVID-19 Vaccine Hesitancy Speaker Series presented by the Washington Thoracic Society. I'm Susan Altman, Executive Director of the American Lung Association in Washington. Many Americans are still deciding if they will get the COVID-19 vaccine. The American Lung Association is proud to work with our partners to provide culturally relevant, science-based, factual guides about COVID-19 vaccination. National vaccination initiatives in the U.S. support the critical work of achieving health equity for all Americans. Along with our presenting sponsor, the Washington Thoracic Society, we're appreciative of the sponsorship support from PhRMA and the Fred Hutchinson Cancer Research Center, along with media coverage from Cairo 7 and Cairo 7 Cares. A few housekeeping items. We will have the opportunity to take questions at the end of the program. Please use the chat feature at the top of the toolbar to submit questions. This call is being recorded, and we will send out recording links after all of the speaker series have been completed. 2 weeks ago, we began this series discussing vaccine hesitancy, laboratory safety, production and distribution, and the role of systemic racism. We were joined by Dr. Stefan Wallace from the Fred Hutch COVID Prevention Network and Courtney Christian from PhRMA. Last week, we were joined by Dr. Ben Danielson to have a conversation regarding vaccine hesitancy in the Black African American community. Today, we are joined by Dr. Dakota Lane, Medical Director at the Lummi Nation, and Dr. Victor Waters, Chief Medical Officer at Dignity Health and National American Lung Association board member, to discuss vaccine hesitancy in the Native American and Alaska Native communities. Dr. Dakota Lane serves as the medical director for the Lummi Tribal Health Clinic. He is the first Lummi Nation member to serve in this capacity. He graduated from the Weill Cornell Medical College in 2013 after switching careers from his electrical engineering degree from the University of Washington. Dr. Victor Waters serves as the Chief Medical Officer at Dignity Health, St. Bernardine Medical Center, a 342-bed nonprofit hospital in San Bernardino, California. Dr. Waters lectures about COVID vaccination and physician liability risk during the COVID pandemic. He has prior experiences in vaccine policies as a former member of the National Foundation of Infectious Diseases, worked as an ER doctor at Rosebud Reservation, Sioux Tribe, South Dakota, as the VA Chief of Staff providing health services for Native American veterans in Wagner, South Dakota, and currently collaborates with the San Manuel Band of Mission Indians, San Bernardino, California. He also has family members that are part of the Caponi Nation, Springfield, Ohio. Dr. Lane and Dr. Waters, welcome. The colonialism and social justice of the Native American people has been documented since before the U.S. independence. The endurance of resiliency is tested time and time again as social injustice like wealth gaps and health disparities continue to stifle communities' ability to secure legacies for their families. Despite social and economic injustice, they continue to stand up for their personal well-being and that of the next generation. Native Americans have been deemed a vulnerable population when it comes to COVID-19 virus. American Indians and Alaska Natives have experienced disproportionate rates of infection and mortality due to the COVID-19 pandemic. According to the CDC, Alaska Natives and American Indian people aged 20 to 49 are at higher risk for illness and death from contracting COVID-19 and should be protected. The Urban Indian Health Institute, one of 12 tribal epidemiology centers, strives to strengthen the health and well-being of American Indian and Alaska Native people in urban communities across the nation. The UIHI is the research arm of the Seattle Indian Health Board, an urban Indian organization focused on bringing quality healthcare to Native Americans in the Seattle area. UIHI conducted a nationwide survey to American Indian Alaska Native people about the COVID-19 vaccination, with 91% of the eligible participants completing the survey and recently released their findings. They found 74% of all participants believed getting vaccinated is their responsibility to their community. 72% of all participants wanted evidence that the vaccine is safe right now and in the long term. And 75% of all participants were willing to receive the COVID-19 vaccine. These rates are much higher than nationwide averages. So we can start with you, Dr. Lane. Can you explain such divergent results and what historical context these results are found? Dr. Lane, can you unmute yourself?
Okay, how's this?
Perfect.
Okay, thank you for having me. And so to address your questions about vaccine hesitancy and willingness, in terms of vaccines in general, just regular vaccines, at least for our clinic, the majority of actually are highly, the majority of students, majority of our patients will get routine vaccinations. In fact, we have a 95 to 99% routine childhood vaccination rates. And this is actually in part a reflection because it's not that long ago that our grandparents experienced and suffered from many of these diseases. And so at least here at Lummi, for many of our grandparents and elders, they've always been a strong advocate for getting vaccines. And so that is why, that is why the numbers that you see nationally that you just announced, 74% are willing to get vaccines, kind of just, I think that reflects the history of infectious disease within Indian country. And that it's actually not that long ago, like my grandpa had TB. And so it wasn't that long ago that many of our community members suffered from those same diseases that vaccines protected against.
Thank you, Dr. Lane. Dr. Waters, did you have anything else to contribute? Dr. Waters, can you unmute yourself?
Can you hear me now?
Yes, thank you.
It really is a wonderful example of how vaccine immunization should be implemented. It starts from the top. It starts from collaboration. So you have leadership from IHS, you have the tribal leaders, you have collaboration with the government and accessing, getting the vaccines out to the populations, really buy-in and a consistent message. That's a little bit different than what's happened out in the outside of the tribal nation. There's been a lot of confusion, mismessaging, misinformation, where you have just great leaders and examples speaking in the native language oftentimes, and entrusted people to give the message to the communities, and a great sense and mission of self-preservation. I think Dr. Lane kind of referred to it, the fact that there's a historical context when you talk about smallpox eradicating almost 95% of the population. There is a very long-term memory about that and a sense of community. Again, a little bit different than outside tribal nation.
Thank you. You referred to smallpox, going back to Spanish flu in the early 20th century and the decimation of the American Indian Alaska Native population in the century prior. How do you think those results impacted the current attitudes toward COVID-19 and vaccine? Dr. Waters, can you comment?
Yeah, so I alluded to the smallpox and as well as the Spanish flu. Again, it's a devastating impact. And the wonderful thing is the stories and the historical context is passed down from generation to generation. It's just as Dr. Lane has shared about his grandfather. And that makes all the difference in the world. My history, my legacy, and the impact it's had on families that are connected to me matters. And because of that long-term memory, there is great incentivization to see vaccination go through, which counters all of the challenges and barriers that we have traditionally seen. And we still see it in the native tribes, but there's been a much better community effort to see this successful, and I'm really proud of that.
Thank you so much. Dr. Lane, did you have anything else to add?
And actually, just, I would echo what both of us had just said, is that it's just kind of the top-down approach. You know, our tribal government strongly encourages vaccines. All of our elders were one of the first to be vaccinated and proudly stood up to be vaccinated for COVID. So it really just continues kind of that historical knowledge about it. And so, yeah, I think you know, in general, at least here at Lummi and kind of the numbers you mentioned earlier, just reflect the willingness of tribal members to be vaccinated.
Thanks so much for that framework. The Indian Health Services, IHS, that Dr. Waters alluded to, began working with the tribal communities and IHS tribal and urban Indian health facilities in September 2020 to consult and confer about the COVID-19 vaccine plan for Indian country. How has this vaccine distribution differed from vaccine plans in the past? Can we start with Dr. Lane? Can you please unmute yourself?
The mute button, I'm sorry.
Okay.
The vaccine distribution was different. You know, traditionally we would do it in a routine health visit for a lot of our vaccines, but given the nature of COVID, we had to do this rapidly changing strategy. And the very beginning, vaccines were scarce. And so we had to reach out to the most vulnerable, in this particular case with our elders, and also the medically vulnerable. And then as it became more and more available, we moved from just opening it only to tribal members, but we quickly realized that a lot of tribes actually had enough vaccines, not just for their community, but also for the surrounding community. And eventually, at least here in Washington State, this was, and also in many other nations as well, they offered vaccines to non-tribal members as well, because we quickly realized that our community was only protected as long as everybody was vaccinated. And so instead of entirely focusing on our own tribe, we were in a position of offering vaccines to the surrounding community. So our model had changed drastically. Now the mass vaccinations have kind of run its course. And now it really is down to a ground game of literally driving vaccines out to homeless camps or to areas where people need vaccines. And so it's just almost, you know, New York Times highlighted as a hand-to-hand combat with COVID. And so that's kind of where we are now. And yeah, so that's kind of in summary what our Lummi experience was with the vaccine distribution.
Thank you. Dr. Waters, can you comment on the difference between vaccine distribution to tribal nations now with the COVID-19 vaccine versus with prior illness? Can you unmute yourself?
Yeah, can you hear me now?
Yes.
Yeah, the Operation Warp Speed has really, it's unusual to very different than what we call the traditional immunization policies and implementations to communities. I mean, this was a fast track. So just in and of itself differs so much in every regards from the tribal and to the communities at large. But one of the biggest differences is the fact that the IHS was able to receive a significant number, as Dr. Lane referred to, a significant number of vaccinations across the tribal nations. That per capita was really good to then have resources to provide non-tribal members. That is a big deal because in communities of color, that didn't happen. Distinction. The access and the commitment to get the vaccine was probably one of the biggest life-saving steps in treating, and a commitment, and actually a commitment to tribal law, you know, to make sure the vaccination was done. And I have to applaud that kind of collaboration. It may have fallen apart, it may have been slow, but the decision to use IHS was a big decision and had made a difference versus the way it's done outside, particularly to community of colors that have been hit just as hard. Remember, the Native American, when they are hospitalized, they're 4 times more likely to be hospitalized when you compare it to the average population, and even higher when you think of the communities of color. That just tells you how prone or how at risk the Native American population is, and yet and still they got this vaccine out and quick, and that's something really, again, to be proud of in that strategy.
Thanks so much, Dr. Waters. Dr. Lane, the Lummi Nation has had an extraordinary result from your COVID-19 public health program. I'm hoping that you can give us a little bit of background and history and discuss how it has been unique.
Yes, thank you. I'd like to share a few slides, if you could pull those up. Because I think I have some data sets and points that I'd like to bring up. Because I think the Lummi experience, if there's one thing that I could hope that people take away from this, is that just as there is really strong data that shows that we have higher risk, I also believe with good governance and good public health measures, you can actually mitigate the majority of those risks. I actually don't see the slideshow on my screen.
It is showing in the presentation.
Okay, that all I see is a blank screen. I wonder if that's okay. Can you? I'll just go through with my.
Yes, currently showing public health during COVID-19 pandemic,
Okay,
and the pictures around what your testing program was and your new clinic.
Sorry, which slide is it? Sorry, because I think there's a glitch in my Microsoft Teams. Unfortunately, I apologize. It's not showing up.
Can we go back to Dr. Lane's first slide?
Oh, okay. Yes. So the background of Lummi Nation. I think, given the nature of the audience in this, I think it's just I'd like to do a few slides just describing who Lummi is and what we are. You can see that. I believe on this slide that shows a picture of the northwest corner of Washington State. And just in the very north corner is the Lummi Nation, our reservation, which is actually closer to Vancouver, Canada than it is Seattle. We have about 5,300 people enrolled in our community. Next slide. And is this a picture of kind of fishing?
Yes.
Okay, so you see that the majority, we are a fishing community. I grew up fishing salmon, crabbing, clam digging. Unfortunately, fishing stock has dwindled, but nonetheless, there are still many people who fish. Next slide. And I believe this is a picture you should see culturally rich traditions with many of our powwows. You see a very nice strong-looking man there on the right. That is our former late Chief Bill James, who actually recently passed, not from COVID-19, but he has been one of our leaders. And if you go to the next slide, I believe it talks about public health during COVID-19 pandemic. So in the very beginning, our strategy was very much first off, the things were put in place way before the pandemic. The Lummi Council decided to start a public health department in 2016. And that really started to build the infrastructure for a public health department. And when COVID-19 came along, we basically had a multi-pronged strategy. One is rapid identification of all positive cases. And doing so meant making it easy for people to get tested. So we created, like everywhere else, a drive-through. That's me getting tested in the upper right corner there. We also had a really strong quarantine all cases. There are many house insecure tribal members. If you think about it, imagine you and suddenly you're COVID-19 positive and you're not vaccinated. You probably don't want to come home and expose your family. So we actually identified 5 to 8 houses that we kept and maintained, and we put positive cases in those houses, and we provided them with food, DVDs, internet to make it so that they would stay and remain quarantined. And then the last part is effective contact tracing. So that was kind of, much like the rest of the national strategy, that was our basic public health measures. Next slide. I would also like to highlight, I believe it says Lummi Council response.
Yes.
And on the picture here is our tribal chairman, Lawrence Solomon. He is a former Marine, and he along with 10 other council members represented the council. And this could not have been done without political leadership. So they listened to our recommendations. We passed appropriate laws when appropriate. And then they advocated for federal and state level access to resources. And they were an extremely important part of our strategy. So it's very important to recognize how important political leadership is. Next slide. One of the very first things that we were concerned about during the beginning of the pandemic, I believe it says alternative care site. Is that what it says on your screen? Okay. We were concerned about hospitals being overwhelmed. And this was done in April of last year. And because at the time, if you recall, Italy was health system was being overwhelmed. And our health team looked at, and we were really concerned about our hospital's system, not the hospital itself, but just the system being overwhelmed, that we create and built our own 23-bed facility. Think of it as like a step-down unit. It wasn't a hospital, but if the hospital were to become overwhelmed, we would be able to take any of our Lummi tribal members, and we had IV infusions, oxygenators, even basic IV fluids and antibiotics. The good news is we never needed it. So, we were very fortunate to have this set up. But what this did is that it demonstrated to our community that we were prepared and we were doing everything we can to get ready. Next slide. And I believe you see a graph now?
Yes.
Okay, so this is this graph represents our policy response from March 2020 to September 2020. What it is a logarithmic graph. You see 4 different colored lines. The orange line is it represents a doubling of cases every day. So the orange, I believe it's the orange line, or the steepest line is doubling of COVID cases every 4 days. The next line is a gray line on my screen, the doubling of cases every 5 days. The following one, yellow on my screen, is doubling in 7 days, and the lowest slope line is the doubling every 14 days. And then you see this other blue line that floats through that kind of transects all those lines. The blue line represents the number of cases that Lummi had in the beginning of the pandemic. Can you start hitting a couple slides forward? You see some arrows pop up. The first arrow is March 12th, where we had our first case. And that was the start of our pandemic, and we were prepared for it because the following day is March 13th, and we looked at the Spanish flu and saw that schools closed right afterwards to help contain the flu. So we thought we'd try the same thing, and we closed the schools on March 13th. 6 days later, on March 18th, we closed our casino. And I mean, keep in mind, the casino was our main revenue of resources, and like I said, having political leadership was important, and I can tell you the political leadership was not happy with our recommendations to close the casino. But nonetheless, after a lot of robust debate, we closed the casino. And then shortly thereafter, on March 22nd, we placed in a shelter-in-place order, and that's still in place to this day. But what's interesting is you can see that the slope of our line roughly parallels doubling of cases every 4 days. And it took, when we flattened the curve, it took all of these policy implementations to really flatten the curve. And we were able to do it within roughly 2 weeks because just of the lag of the COVID. And you could see that we kept it in place. And then if you fast forward a couple, you see a few more arrows on the next steep slope. And that was our second outbreak, April 28th. We had 22 cases by then. You can see it was really steep. We were doubling every less than 4 days. And now you should pay attention to how quickly, with each successive outbreak, we were able to clamp down with the public health measures, effective contact tracing, effective testing, and then effective quarantine. If you fast forward a few more, you'll see your third outbreak in July 20th and July 30th. And then finally to the very end in September. And the big picture you want to take out of this is, in addition to these policies, we were also really fine-tuning our public health response. In the very beginning, you can see we were panicking. Then you go to the second outbreak. Okay, now we kind of have an idea of how to quarantine and contact trace. Then you go to the third outbreak and you can see a significant improvement in our public health response and containing the virus. And so that is very much a story of our public health policy. Can you go to the next slide? I believe it says Lummi Public Health data. It shows our daily COVID cases. Is that correct?
Yes.
So now this is actually the COVID cases within our community throughout the entire pandemic, all the way till May of this year. And it very much reflects the national data. You know, we had a first wave in March and April, and then again in July of last year, followed by this third wave that came from September to December, and then that merged in with the terrible fourth wave in January until now. And so that's just, you know, our story is very much the same. However, if you go to the next slide, you'll see that despite having high COVID cases, you should see, let me just confirm, you see all these numbers in Excel spreadsheet, is that correct?
Yes.
Okay. It should say June 2nd of 2021?
Correct.
Okay, so this is this table is a little bit busy, so I'll just do my best to explain. You have one with the Lummi table, and then to the right is the Whatcom County, which is our surrounding county. You can see we've had roughly 522 positive cases since the beginning of the pandemic. Of those, 514 have recovered. Right now, we have an active caseload of 5. Those 5 are actually all not fully vaccinated or unvaccinated, so the vaccines are working. But the other thing I want to show is the positivity rate. In Lummi, it was 8.3%. In other words, 8% of our tests came back positive throughout the entire pandemic. For comparison, Whatcom County only had a 3.8% positivity rate. And so certainly Lummi's carried a higher burden of disease. And I have some others here, the 7-day and 2-week positive. Those are just to kind of give us an idea of which way the virus is going in the short term. But the pandemic-wide, from the very beginning, we've had an 8% positivity rate. At its worst, we were at 22% positivity rate in February of this year. But nonetheless, and then if you continue down the sheet here, you'll see that we have hospitalized deaths. And we've had a total of 13 hospitalized. And so and while Whatcom County has had 420 hospitalized patients. And what I want to highlight is the number of deaths. Lummi has been extremely fortunate in that we've only had 3 deaths, while Whatcom County has had 98. That works out to be a death, I hate the sounds of this, but a death rate of 0.5%, while Whatcom County is at 1%. So in other words, a way to think of this is, despite Lummi having a higher burden of disease, roughly 8% of positivity rate, we had a much lower death rate, almost half of what Whatcom County was. And I think, in my opinion, this reflects that public health works. When you have a public health team with strong political leadership, it can provide excellent protection against this virus. Of course, there's more like vaccines and masks, but I want to tell you, just even quarantine, contact tracing, all of those are also just as important. Next slide. So you should see case rate for Lummi Tribal members.
Yes.
Okay. So right now, this is just a reflection of how we are doing right now. The 2-week case rate, assuming we have 2,800 people who live on the reservation, is about 178. For enrolled tribal members, it's about 94 per 100,000. For comparison, Whatcom County and Washington State ranges from 180 to 199. Okay, next slide. And you should see the Lummi public health data, how we are exposed.
Yes.
This came out by my public health team about a week and a half ago, and I think this is a true reflection of also what happens in Indian country and why we have such a high burden of disease. And it's really about, first you see a pie chart here, and we looked at all 500 plus cases, and we looked at how people contracted the virus. And you can see the biggest slice of the pie is this blue section, about 43%, and that is household gatherings. So 43% of all of our cases came from some sort of household gatherings. Here at Lummi, and I think the rest of Indian country, we like to gather. We get together and have all sorts of dinners, ceremonies, etc. So and there's always, so that's not a surprise. Also, here at Lummi, we do have a very high number of people who live in a household. The average household contains 7 people. For some of our worst outbreaks, these households had as many as 14 people in a household. So that is a really high. The next biggest part of this pie is the secondary, what we call identified as secondary household transmission, which is similar, but it's about 34%. And that's when we identify someone who was previously positive and then brings it to a household and then gets the entire household positive. So it's kind of a, so you can safely say that about 77% of our transmissions occurred from some sort of household relationship. We had very few that got it from travel, very few from restaurants, very few from daycare. And when the other way to look at this too is when you think about human psychology, even in your own lives, when you are at home, you're more likely to not wear your mask. So, and when you're more likely to not wear your mask, you're more likely to be exposed. And so, nobody wants to wear a mask around their family or friends. It's really hard. And so, and I think that reflects some of the data we have here. Okay, next slide. I believe it shows vaccinated tribal members now.
Correct.
Okay, so this just came out about 5 days ago. We have about 2,800 tribal members who live within Whatcom County. Of those, half of them, or 46%, are fully vaccinated, and then an additional 6% have initiated the first dose. We still have 1,300 who are unvaccinated, and I'll be honest, this initially surprised me. We had probably given out over 10,000 vaccines throughout this entire county, and as I look into it, I think it's more a relation of just access. Like this community is not one to schedule an appointment. They just show up, and if it's available, it's available. And so and so I think we just have to go, kind of rethink our strategy, including incentives, monetary incentives, anything to get them to come in. Okay, just a few other things I want to acknowledge. Can you go to the next slide? We started doing vaccines. This is made Seattle Times. This is our first elder who was vaccinated, Jim Scott. We had received 300 doses way back in December. And he, as we had mentioned, Dr. Waters and I have mentioned, having our elders be the first people that are well respected in our community be the first to get vaccinated really helps drive the vaccine, increase vaccination rates. And so go to the next slide. A few comments I want to make. You know, I have a really spectacular team. And the public health director, Dr. Christina Toledo, is one of those people. She's went to med school with her, and she ended up getting trained at Harvard. She worked tirelessly throughout this pandemic. And you can see the bottom picture here. Dr. Toledo is right next to our elder Jim Scott, and then there's me on the left. And then in the bottom picture is our first shipment of Pfizer vaccines, and that's our -80 freezer. Yeah, she was a key member. The next slide. One of the things with vaccine distribution is how much time and direction it takes. And we quickly realized we needed a person to run this, and that's Dr. Justin Iwasaki. And he really led these mass vaccine drives to really try to get vaccines out. Like Dr. Waters said, the IHS had a huge distribution line. And the name of the game is the faster you get out the vaccines, the more vaccines you get. So this picture here is of us at a Boundary Bay, a local brewery, where the National Guard has agreed to give out vaccines, and then some construction companies agreed to sponsor a free beer for each shot you get. So that was way back in April. And I think I will stop here because I think the next slides will go to other questions. Thank you.
Thanks so much, Dr. Lane, and congratulations on really good results and continued success. Dr. Waters, turning to you, the severe COVID-19 burden that's been reported in American Indian nations, can you describe why there is that discrepancy? You identified previously that there's been this discrepancy in all BIPOC communities, but can you speak specifically to Indian Nation?
Yeah, you know, one of the things that Dr. Lane mentioned is the contact from household and community. So you add to the fact that their households may be small, number one. Number two, maybe multi-generational, and that compounds the risk for acquiring COVID. And then you add the fact that you have already health disparities, particularly with diabetes and hypertension, morbid obesity. You add those significant risk factors, you get a much higher, as I said, 4 times higher rate than the general population at hospitalization. What's fascinating, though, is the death rate is not much different, even though it's higher compared to the general population. When you compare it to communities of color, it's around the same. So yes, they come into the hospital, they're sick, and they have all the co-risk factors, and they die just as high risk as the communities of color. So the treatment regimens and everything that's been employed, they may still not survive that. So it is very important to understand that the community, having the tribal nation with the community mindset, and still not wanting to separate and wear masks, and the easy transmissibility, because you know it's highly infectious, really placed a significant burden. But I want to add really the fact, and this is a critical point, the fact that you had the Pfizer vaccine that required below freezing temperatures, and to deploy the vaccine in community and rural communities really adds to the amazing speed and safety and benefit and teamwork to have this happen, particularly early on. I know the current recommendations, you don't need to have it in super cold freezers. But again, the early implementation, the quickness has really abated the high risk that the community was under. And I tell you, it really is amazing and something to be proud of. I'm gonna keep saying that because it just ain't happening elsewhere.
Thanks so much, Dr. Waters. And staying with you, the U.S. joined an international community in the COVID-19 warp speed vaccine creation, and you alluded to this in previously. Can you describe how this accelerated effort has produced safe vaccine for all populations?
You know, that's always been the question when things are being produced so quickly. there is a cause of concern about its safety, particularly messenger RNA and Pfizer and Moderna. There's a question, well, what is this? You know, on average, you're right. On average, the community, it takes about 10 to 15 years on average to get a vaccine produced and studied and saved. All what was done here was to quicken the steps, not to skip the steps. Very important to understand that. The numbers that were studied was done, that was one piece of it. So the numbers were adequate to assess the risk, particularly in the 3-month period, because most vaccines are going to have adverse side effects within that period of time. It still didn't answer a lot of communities' questions, and I'm sure there are still, but what about long-term effects? It's pretty unusual, particularly with messenger RNA and its historical use and studies. It's unlikely there's going to be any of those impacts. But the other very strong piece, the other very important piece of this is the fact that there was already ramp up to produce and distribute the vaccine before it was even approved, even emergency use. That's a big deal, because most vaccination programs, you wait until the dot is sealed, that the FDA approves the vaccine, and then they go out and contract with distributors, and then but it was already in the phase of rapid production well before it was approved. That type of collaboration helped the process, and no skipping steps. And that's what I've had to say over and over in many of these webinars to really mitigate a lot of the doubt and confusion, because particularly in communities colors, there is a lot of distrust of the medical community, and even in the native tribal lands, there really is some distrust when it comes to experimental. When that word gets out there, it does create some pauses.
Thanks so much for discussing the safety. Dr. Lane, turning to you, first we'd like you to comment about clinical trial representation and how representation was impacted by Operation Warp Speed. And then our next question will be about the specific experience around the Lummi Nation.
Sure, thank you. Yeah, so our health team recognized early on about the importance of vaccines as part of the strategy against COVID-19. In fact, when we presented to council, they asked us, why do we have to shut down? What's the point? In addition to saving lives, we also were saying, we need to wait for a vaccine. So that opened up the discussion to us about how do we vaccinate people? And certainly there are those on at least Lummi Council who are highly skeptical of all of these vaccines, and they, how quickly it was, just like Dr. Waters had mentioned. But nonetheless, in early April, we received an email from University of Washington looking for tribes who are willing to participate in vaccines. And, so I responded, and one of the things that took a lot of groundwork with my community was explaining why it was important that we at least consider participating in vaccine trials. If you recall, a year ago, we knew that vaccines may become available. We had no idea that they were going to be as effective as they were. We did not know, mRNA was a really new technology, and we were, like, well, good luck with that. And so, but we also knew, the health team also knew that the majority of participants in these vaccine trials are white. I think for Pfizer, 95% were white. For Moderna, it was even higher. And so, for us in the Lummi community on the ground here, there was this catch-22. People would not do the vaccines because no tribes were involved with the trials. But then again, if no tribes were involved with the trials, how do we expect to benefit from vaccines? And so it took a lot of discussion and conversations with elders, tribal leadership, and eventually we agreed to participate in a vaccine trial. And thankfully, we had a a great partner in University of Washington. And I'd like to pull up my slide. Is it up already?
Give us one moment, it's coming.
Sure. The slide that's coming up is it's just one slide, and I'll try to keep it as short as possible. Is the team that brought together, in this case it was Novavax, Dr. Scott McClellan, who's the UW infectious disease and the principal investigator, who agreed to allow this trial, to work with us to bring the trial here. The second, and he's on the far left, and the second from the left is Dr. Bill Freeman. And one of the things that we had to do to make sure that we could minimize the risks to Lummi community specifically is we are fortunate in that we have our own IRB board from Northwest Indian College, and it's chaired and run by Dr. Bill Freeman. And this IRB board reviews all research that is performed within Lummi and makes sure that the tribe would benefit. Then there's me in the middle there, and then Dr. Frank James, who also is a public health officer for a nearby tribe called Nooksack tribe. And Lummi and Nooksack partnered to participate in this phase 3 trial. Long story short, it took about 4 months to bring this, to go through all of our regulatory procedures for review by our IRB, for approval by council, and then eventually bringing the Novavax vaccine to our community. We ended up enrolling 64, which seems pretty small, but the outside influence of starting this vaccine trial cannot be understated. We were discussing vaccines way back in August. And what that functionally did is all of the tough discussions that a lot of communities are having now about vaccines, don't want to be guinea pigs, is coming too fast. How much is political leadership being paid to give out these vaccines? We had all those discussions way back in August. And I can tell you it wasn't easy. I've had many of my family, my friends, relations, say, Dakota, nephew, grandson, what are you doing to us? And it took a really long conversation, like, listen, this is volunteer. Nobody's being guinea pigs unless they want to, volunteer to participate in this trial. It really is a historic trial. And what that did and served was to open the discussion to all of the historical things that at least Lummi has experienced with regard to research and vaccines. Although our vaccine experience was quite good, they were worried about research. So that was a kind of the biggest issue, is that we had bad research done here at Lummi and have been burned by it. The worst one was back in the 80s. We had a researcher come and do studies on fetal alcohol syndrome, took pictures and said they were going to help us. Then they went off, did their career, and then used those pictures in their presentations. So pictures of our children without telling or asking permission from any of the families. And so that researcher then presented, as an expert, and would go around to all these communities, and lo and behold, she came to one of the communities and showed a picture of a young child. And within the audience is one of the grandparents who stood up and said, "That's my grandchild. I never knew that my grandchild had fetal alcohol syndrome. How dare you?" And this is back in the 80s. There's a little bit of Wild West, and still a Wild West of medical research. But nonetheless, when I brought the vaccine trial up, every single elder said, "Don't you remember that study, and fetal alcohol? Aren't they going to do the same to us?" And I had to say, no, we now have a process. We now have our IRB board. It got, I presented to council. I presented to general, our whole community, and just took a lot of work. And the end result is that it really opened the discussion about vaccines, what kind of technology it is, and so for that, I'm fairly grateful. One side note that I think is worth noting is that as part of the trial and preparation, back in July, we got a -80 freezer, -80 freezer, not knowing that Pfizer was going to be it. So even participating in these trials really brought a lot of benefit because we actually had the infrastructure in place to get the Pfizer vaccines. And one final comment, thanks to the trial, I believe we're one of the few communities that has 4 vaccines in our community: Pfizer, Moderna, Johnson & Johnson, and Novavax. And I still think that's important because you want a diverse option of vaccines, because who knows when the next variant may break through. So having a diverse option of vaccines also infers a lot of protection on the community. Thank you.
Thanks so much, Dr. Lane. The most influential people are often those closest to home, gathered around the kitchen table and sharing thoughts about life and current events. You've both alluded to the fact that Indian Nation are very supportive of gathering. How do individuals and communities contribute to vaccine acceptability? Dr. Lane, can we start with you?
Yes. So that actually is one of our that is actually one of our strategies. Is we basically did our elders first, who we all look up to, and so anytime they were around their family, they'd be cajoling, talking, the elders would be dragging their unvaccinated family members down to get vaccinated, and that is been a huge part of our vaccine strategy.
Thanks so much. Dr. Waters, did you have a comment?
Sure. I mean, absolutely. From elders to healthcare providers to Dr. Lane himself, that is what speaks for itself. In other words, nurses, we've had challenges with even nurses getting vaccinated, and they are a huge component in terms of the care, rendering care directly with COVID patients, either outpatient or inpatient. So making sure that they're outspoken, that they've received the vaccine. And of course, just individual families mentioned. Again, there's been a lot of hype about safety. So everybody wants to talk about how it felt. They felt sad, they felt fatigued, they felt this. And that's a reason for, even in out west, there was vaccine hesitation after their initial vaccine. So we talk about first dose vaccine, but still the people are hesitating or getting the second because they are fearing worse side effects. If they felt this bad the first time, they may feel worse the second time. So those are the kind of barriers that we have to get across. And that means more people sharing their experiences in a good light.
Thanks so much.
You're welcome.
As a reminder, we do have time now to take a few questions. We do have a couple comments that I'll read to both of the presenters. Thank you, Dr. Lane and Dr. Waters. This is excellent information on vaccine hesitancy. Communities protected with vaccination, even Lemmy driving out to homeless, and also the word on collaboration in tribal communities being strong due to history and smallpox impact to survival. And also Dr. Lane's presentation was amazing. Thank you. Here's one more additional question. Dr. Lane, I'll start this off with you. If you have a choice, is one vaccine better than the other? You identified that you had opportunity in Lummi to have 4.
Yes. So for me, I think I've heard either Dr. Fauci or someone at the CDC or NIH say this: the best vaccine is the one you want. I got Pfizer because that was the first one available to me. I would have gotten others if that was the only one available. So and I think for some people, interestingly enough, when we had the Johnson & Johnson, initially a lot of tribal members liked that one because it was one shot, but then all the media came out, I think is rather somewhat unfortunate, but about the clotting. So then the tribes our community kind of turned against that because we had other options. But locally, there was a local non-tribal community within our county who would rather have one shot. So we actually gave all of our Johnson & Johnson to that community because they just wanted one shot. It's 300 vaccines. And so, I think the best vaccine to get is the one you want. All of them will prevent you from having hospitalizations, which is what the ultimate goal is, or severe disease. And so that's, yeah.
Thanks so much. Dr. Waters, one question directed at you. If I've already had COVID-19, do I still need to be vaccinated?
Yes, you do. So the immunity protection is only for 6 to 7 weeks. So what that means is you may not need to get the vaccine, and you should get the advice of your physician, but you don't need to get the vaccine immediately after you're sick, and you should be asymptomatic. So again, following CDC guidelines, the question is absolutely. It will not confer absolute immunity against the COVID virus. And as we know, the efficacy of the vaccine is not 100%. So even though you may get the vaccine, it doesn't confer 100% immunity. So we have seen, and it does exist, breakthroughs of the virus. So even more so to continue the distancing, and particularly people you don't know, all those kind of things still flow because we're not talking about 100% effective vaccine.
Thanks so much. Thank you so much, Dr. Lane and Dr. Waters, for your expertise. One last question we'd like to ask, what is one takeaway that you want our participants to remember from today? Dr. Lane, we'll start with you.
Thank you. It's been an honor and a pleasure being a part of this. Probably the one takeaway that I would say is that when you have the right pieces in place, the right public health team, the right political leadership, you can do great things. You can protect your community. I do, and I think a lot of tribes are pretty well positioned to do that. And even though we do certainly have higher risk factors, a lot of tribes did a lot of good work in protecting their community. And I hope that at least the Lummi experience demonstrates what's possible to the rest of the country when you have kind of everybody running on the same track. And so we've been very fortunate, a lot of luck, and good judgment on all of the leadership here at Lummi. So thank you.
Thank you, Dr. Lane. Dr. Waters, one takeaway?
Yeah, for me, the purpose I'm on this call is to really stress the need to get vaccinated. It's not over yet. You still have the COVID variant out there. You are still at risk, particularly those who are hesitating. There's no time to hesitate. There has been enough time, and millions of people already vaccinated have not gotten the kind of side effects. So the sideline, watch and wait is really not the wisest thing to do. So my take-home point is get vaccinated, speak to your physician, speak to people who've been vaccinated, and get vaccinated. There's really no reason to be sidelined and go into this kind of, well, if everyone's vaccinated, then the rate's low, I don't need to be vaccinated. We call that another form of herd immunity. That's a dangerous game to play. That's Russian roulette to play. So don't just sideline and wait for everybody to get vaccinated and assume you'll be okay now that the rates are down. That's a very unsafe way of thinking. So that's my 2 cents.
Thank you.
You're welcome.
The American Lung Association is pleased to share our Better For It Vaccine Toolkit series. The series now has 4 toolkits available for Black American, Latino, Indigenous, and general population communities. The toolkits are designed to help to reduce the morbidity and mortality of disease by offering trusted resource on the benefits and importance of immunization, particularly in communities disproportionately affected by COVID-19. Each of the culturally relevant toolkits provides the opportunity for individuals and communities to fact check and supplement their own research on vaccines, especially the COVID-19 vaccine, to encourage a dialogue among friends, healthcare provider, pastor, and family members, to share accurate information on social media, and to learn and understand the contributions of scientists and public health advocates who are helping to bring the pandemic to an end. The Lung Association is asking you to provide this information with your networks as appropriate. These toolkits can be found and downloaded at lung.org/vaccine toolkit. The speaker series will continue next week for our final installment illustrating the unique concerns in the Latino communities. We would love to have you join this episode and share the American Lung Association toolkits with your community and networks. To join these discussions, please use the original RSVP link. Recordings of all of the speaker series will be posted on Cairo Care's digital platform, as well as emailed out to all RSVP participants. The recording of this series will also be posted on the AIHC Tribal and Urban Indian Health and Immunization Coalition webpage. Sorry. And finally, thank you for joining us today, and thank you for your contributions, Dr. Lane and Dr. Waters.
Thank you.
Thank you.